Welcome to Module 4. So in the previous module, we spoke about the risk involved with female androgen use. In this model, I want to provide you with some tools you can use to monitor these risks in female athletes, clients, or yourself should you decide to venture down this path. Remember that this information is for educational purposes only and should not be taken as medical advice. Any decision to engage in performance-enhancing drug use is done so at your own risk. So how to monitor virilization? For voice deepening, you can use a voice frequency tracker such as Spectrum, and this is an easy way to track deepening of the voice. Ask your clients to simply repeat the same 3 sentences daily from the beginning of exposure and match this throughout the duration of use to exogenous androgens. For hair loss and facial changes, ask them to take weekly images of their hairline to keep an eye on androgenic alopecia, and pictures of their jawline to monitor for changes or enhancements to facial features. For fertility, you can get them to track their basal body temperature to make sure that they're still ovulating every month. Remember that a menstrual bleed is not an accurate representation of ovulation, as well as their serum levels of LH, FSH, E2, and P4. For organ health, get blood work done every 12 weeks to offer insight into the health and function of the reproductive organs, heart, kidneys, pancreas, and liver. As mentioned previously, similarly to males, the safer use model advocates for only the following compounds that have been tested in human clinical use. We have stressed that non-androgenic and ancillary compounds alone will bring about very appreciable results in a female. And I would consider it best practice that a female use these compounds alone for her first year's exposure to physique enhancement compounds. From there, she can assess her needs and risk tolerance for introducing additional androgens. The androgenic compounds discussed in the safer use model are going to be testosterone and DHT derivatives. So we got primobolan, masteron, or anavar. It's not a very big list. But when it comes to compounds we should avoid, in short, it's going to be everything but what I just mentioned before. But specifically, trenbolone. There is no clinical trials on trenbolone in females, and it is likely to be highly virilizing. Dianabol or D-bol, again, high risk of virilization. Boldenone or equipoise, and this has not been approved for human use and is highly renal toxic. Then we have proviron, which is just a pure DHT, and is simply a masculizing hormone with very little anabolic benefit. We have halotestin, again, has no application and poses far too many risks on females. There are safer and more effective options for androgen sensitive females, and any other compound that has not been approved for human use, including SARMs. Let's go over duration of use. This is specific to the use of anabolic androgens. For the female's first year's exposure to AAs, it is best practice to keep these to 4 to 6 week blast phases and as infrequently as needed to achieve the desired goal. This would be limited to 2 to 3 blasts every 12 months within a surplus, where the female is less likely to have any of the aforementioned symptoms of relative energy deficiencies discussed in Module 2. After that, it is crucial that the phases are mapped out to allow for enough time in between blasts to reduce the risk of androgenic side effects and accommodate for one blast likely falling into the last 6 to 8 weeks of a contest prep. Once non-androgenic performance-enhancing drugs have been exhausted and a decision is made to progress to the next level of risk acceptance, a DH derivative is going to be the next compound that could be introduced for enhanced females. This will allow the individuals to increase the need for proteins secretion whilst also decreasing sex hormone binding globulin. Because they will be using these androgens in short blasts, or at least should be, DH derivatives are far less suppressive compared to 19-NORs and tend to be less advanced in health side effects, namely their level of toxicity. Whilst anabolic androgens do accrue approximately the same rate of muscle tissue when compared milligram to milligram, the virilization profile of each androgen does differ, and this is something to pay attention to when working with female athletes. By keeping the aforementioned non-androgenic compounds in play whilst introducing anabolic androgens, multiple pathways can be leveraged year-round without relying solely on DHT derivatives for increased anabolism. There is no androgenic compound exempt from causing masculine side effects, but within the data, we can see that testosterone and nandrolone carry a higher risk. And when comparing masteron to nandrolone milligram per milligram, masteron showed to present less effects on deepening of the voice, unwanted hair growth, skin changes, and fluid retention. When it comes down to compound selection for females, certain guidelines should be followed. The accuracy of the drug, so if it has been tested for its efficacy, least virilizing, and injectables over orals. Following this and abiding by the suggestion that a DHT derivative is going to be the preferred option for females, we would have primobolan, masteron, followed by anavar. These all have a low androgenic profile designed and used in pharmacological settings with androgen-sensitive females in mind. For Primobolan, the potential starting point for enhanced athletes is going to be 15 to 25 milligrams per week. For Masteron, the potential starting point for enhanced athletes is going to be 15 to 25 milligrams per week. And for Anavar or Oxandrolone, the potential starting point for enhanced athletes is going to be 17.5 milligrams per week, so 2.5 milligrams per day. The dosing for each compound should be based on the individual's level of androgen sensitivity based on her tolerance of testosterone, risk profile, and health status. Hey guys, so I just wanted to walk you through a timeline that I've put together. So this would be a yearly roadmap for someone who is enhanced and going through a contest prep. So this is more towards the bodybuilding, going through their, like finishing off their surplus and then going into a prep. We're going to go into this with the pre-emphasis that they've spent the previous years exhausting all the non-androgenic pathways before introducing the androgens. I also want to just start by saying before we go into this that, again, I'm not a health professional and this is just general advice. This is personally how I would set it up for my athletes. I by no means want you to follow this exactly, and I would encourage you to speak to your health professional about any kind of hormone replacement therapy. So just for the sake of the conversation, I've got this female on a full spectrum of hormone replacement therapy. I haven't put doses in there because, again, that's going to be very dependent on that female, her biofeedback, her physiology, and her serum labs. So let's just say that she's in her growth phase, and obviously we're just going to scale up training volume and intensity as we go through that growth phase. Cardio might be in, cardio might not be in, depending on her output, depending on her food volume, her digestion, her tolerance to those calories, that kind of stuff. And then we've got a recomp phase here. So that's just when she enters a deficit. Oh, sorry, before I go into that, we'll see that we've got blood work getting done every 12 weeks. Here, just at the end of her messing phase, I've chucked in 1 super physiological ranges where we'll introduce that DHT derivative. And then we'll go into a recomp phase, so spending 6 weeks just to pull things back, so that she doesn't end up accumulating too much body fat before prep starts and run the risk of obviously, losing muscle mass and that throughout the contest prep. So that kind of repeats itself, and then we enter the contest prep here. And that's when sort of like the last 6 weeks, we would throw in those androgens. So remember how I said that we've got to kind of accommodate and space these phases out so that there's enough time in between and enough time off for her to recover. And then knowing that the last 6 weeks will probably fall into a prep scenario. The lipolytics in that we will just put in on a needs basis. You can also here, so in between this super physiological phase here, you could even here throw in some clenbuterol for those mTOR phosphorylation properties, and take advantage of that in between going into those super physiological ranges. And you could do so here as well. So, just throwing in maybe 40 micrograms of clenbuterol to support nutrient partitioning and, encourage that mTOR phosphorylation. And then obviously after that, as soon as prep is over, we're going to pull out all the compounds. As far as thyroid goes, we might leave T4 in there until we feel that the female has recovered enough to remove that. But T3 would definitely come out straight away. And then we would go back to our standard hormone replacement therapy. So I hope that all makes sense. Like I did, obviously a lot of this is going to be dependent on the person, the individual that you're working with. Again, their hormonal status, their biofeedback, and what their goals are, their own risk assessment and whatnot.